Good afternoon, everyone. I'd like to welcome you all to the 6th annual Thewlis Lecture in Gerontology and Geriatrics here at the University of Rhode Island. I'm Phil Clark. I'm the director of the program in Gerontology and the Rhode Island Geriatric Education Center here at the university. Initially, I'd like to thank our sponsors who helped to make this event possible. The URI College of Human Science and Services, the URI College of Nursing. We have a few nurses. You can tell the nurses. The URI Department of Nutrition and the Food Sciences SNAP Ed program. Also the Rhode Island Geriatric Education Center and the program in Gerontology. I would also like to draw your attention to the table. It's in the back hallway before you come into the lecture theater that has some information about our Osher Lifelong Learning Institute for people who are 50 and older who would like to take courses at the university, and also for the Geriatric Education Center, which is our training program for healthcare and human service professionals. So if you could take a look at those materials. Also, if you would like to sign up for future lectures and be on our mailing list, we would welcome you to do that as well. At this time, I'd like to invite our Provost of the University of Rhode Island, the Chief Academic Officer, Dr. Donald DeHaze, to bring some greetings from the university. Don?
Well, thank you all for being here. Welcome to beautiful and recently renovated Edwards Hall. I'm glad you have an opportunity to use it for this venue. The university is pleased each year now for 6 years to be sponsoring this lecture focusing on gerontology and geriatrics. This is an extraordinary opportunity to bring a leading scholar and practitioner, Dr. Mezey, we're pleased that you're here, to our campus to share her experiences with the community, and also for all of you to learn a little bit more about what's going on at the University of Rhode Island in this area. The areas of health and wellness, is a new and emerging focus for our university, along with another area which is what we would call interdisciplinary work. That is, faculty and students from different departments coming together to work together on common sets of problems. There are probably few better examples than we have in our university of interdisciplinary health-related work than in the area of gerontology. So it's very important to us that we can invite leading scholars in the world to our campus, that we can promote what we do to all of you, and also that we can advance our understanding of the rapidly emerging issues related to the aging population. In fact, the state of Rhode Island is a poster child for the aging population. We are among the fastest aging states in the country. I think we're about 8th, if I'm correct. And in terms of a population over the age of 85, I think we are the 5th most rapidly aging state in the country. So maybe that's telling us something good about our health and wellness practices, that we have an aging population here that is happily enjoying themselves, living healthy lives, and still contributing and taking back from the community. So this is a real treat for us to be able to every year host this lecture. And we're very, very grateful to all of you to come out and listen, learn, give back, ask questions, contribute. And so don't be shy at the end. I know you'll have an opportunity to ask questions and to share your experiences. Thank you all for being here on the campus of the University of Rhode Island.
Thank you, Provost DeHaze. Before I introduce our visiting lecturer, I wanted to give a little bit of background explanation for the name of this annual lecture, the Thewlis Lecture. I hesitate to ask for a show of hands of how many people would know who Thewlis is, so I won't ask. Dr. Thewlis was one of the founding founders, the key founders of the American Geriatric Society in 1942 in New York City. He was an author of an early textbook on geriatric medicine that was published in 1919. He was also, and this is the link to the annual lecture, he was also a resident of Wakefield, Rhode Island. He studied with Marie Curie in France. He also practiced medicine in New York City. In the 1940s, he was a special consultant to the Rhode Island Department of Health, and he was an attending physician at South County Hospital, which is just down the road here from the university. After his death, there was a book found in his library in his home that had a copy of his letterhead, and the heading of the letterhead said, Melford Thewlis, MD, New York, Paris, and Wakefield. So we thought Wakefield and Paris and New York sound pretty much equal level. That sounds good. This marks the 6th annual Thewlis Lecture. We have been privileged to have had Dr. Kenneth Miniker of Massachusetts General Hospital and Harvard University. We've had Dr. Nancy Faye Jensen of the College of Human Science and Services from the University of Rhode Island. We have had Dr. Jeff Fernie from the University of Toronto, Canada. We've had Dr. Tom Pearls of Boston University. And last year we were pleased to welcome Dr. Rudy Tanzi of Harvard University. Following the lecture, we would invite everyone to please join us for a reception to honor Dr. Mezey, which will be in the URI Alumni Center across the street. We have provided foods that will enhance your lifestyle and help you to age better. So in case you're wondering what those foods are, please come and join us. These are not FDA approved, so just a word of warning about that. Now it gives me great pleasure to welcome our 6th annual Melford Thewlis lecturer, Dr. Matty Mezey. Dr. Mezey is Professor Emerita and Senior Research Associate and Associate Director of the Hartford Institute for Geriatric Nursing at New York University. Her current research and writing focus on geriatric nursing, education, and quality of care for older adults. She has authored numerous books and professional journal articles on nursing practice with older adults and also on end-of-life care issues. Dr. Mezey has received several very prominent national awards for her work, notably the Kent Award and the Doris Schwartz Gerontological Nursing Award from the Gerontological Society of America. And she was the first nurse to receive the American Geriatric Society Nasher Manning Award. The American Geriatric Society is largely physicians, so it's a great honor to be the first nurse to receive this award. The title of Dr. Mezey's lecture this day will be Coming of Age, Negotiating Health and Health Care as We Age. Please join me in welcoming Dr. Matty Mezey.
Good afternoon, everybody, it is really an honor to be here today and to deliver the Thewlis Lecture. And I want to thank Dr. Clark and the GEC here at the University of Rhode Island and my wonderful colleague, Pat Burbank from the College of Nursing for inviting me. And I've had a wonderful lunch today with several people who are very involved in your aging initiatives, and it is just delightful. So I am going to try to talk a little bit about aging from the perspective of things that might be food for thought for you. And I'm going to start by thinking about how to age well. And as you can see from my gray hair, I'm right there trying to age well. And then I want to talk a little bit about the conundrums that happen when we don't age well and when we have the issues of health and disease that are very common in old age. So that's sort of where I'm going to try and take you. As your provost mentioned, Rhode Island is really an aging state. These are the population figures for Rhode Island, approximately 14% of your population, 65 and over, which, as you can see, is above the national average. We think by around 2040 that 1 in 5 people in the United States will be 65 and over. And that is where some other populations are today. If you've been reading about the terrible situation in Japan after the earthquake and tsunami, and you look at all of those small villages that were hit along the northern Japanese coast, many of those villages were populated primarily by people who were aged, with Japan currently having 20% of their population 65 and over. The average life expectancy, if you're 65 today, is another 20 years. So you'd better be thinking about what you want to do for those next 20 years. And I think probably one of the most amazing statistics is that of babies born today, they have an even chance of reaching their 100th birthday. This is really a revolution in our population statistics. Now, as I said, most people are healthy and active, and this is a wonderful photo from a National Geographic article on people aging. This is not Rhode Island, it is California, but every person in this photo is 75 years of age, an older and an active surfer. People age, and they age in a cohort of friends. And this is a photograph, actually, of a woman whose mother is in this photograph with 2 of her very best friends, all of whom 80 years of age and over. And this is from an article in the National Geographic of centenarians, people 100 years of age and over. And there are currently 70,000 people in this country, 100 years of age and over. And this is a woman swimming. And this is a woman in Loma Linda, California. I love this photograph. She is a nurse, a retired nurse, and pumping her own gas here. And Loma Linda is a very interesting population because of their high number of population that have beliefs where you do not drink and you do not, you tend not to eat meat products and you do not smoke. This is a population which has a larger number of people 100 years of age and older than the general population. And this is my very favorite photograph that I'm going to show you. These are 4 sisters. The lady in the red dress is over 100 years of age. The lady on the other side with the striped blouse is, I believe she was 87 when this picture was taken. These are 4 sisters living in Minnesota, all living independently in their community. Now, this picture resonates for me because I happen to have 4 daughters. And in the article that went with this picture, they interviewed either of these women, and the woman who is the younger said, you know what happened? She said, what's so interesting is here I am with my sisters, and no matter how old I am always the baby sister, right? So 85 years and older, she's still the baby sister. But the other thing I always talk about when I talk about my daughters is I always say, I have the best long-term care insurance in the world. 4 daughters is the best long-term care insurance in the world. So we are seeing an aging population. And we are now seeing men catching up with women, but there are still more women who are 65 or older than men. And here again is the life expectancy. And we describe this as a new old age, and I think it really is a new old age. And these are some quotes from people who were surveyed to ask whether they agree or disagree with certain quotes. And so when people were asked, these are the best years of my life, 44% overall of people said, being 65 and over are the best years of my life. Not necessarily what we think, especially if we're younger, and I teach nursing students, and they don't always think that's the case. I'd be happy to live to be 90 years of age or older. 84% of people who are themselves elderly say that's the case. And what's really astonishing is that 33% of people 65 and over say they're middle-aged, right? In their 70s. We have ratcheted up all of our views of what it is to be elderly. Jack Rowe is a very, very well-known geriatrician who founded the Hartford Department of Geriatrics, and he's written a lot about healthy aging. And this is what he says composes successful aging: minimizing disease and disability, maintaining physical and mental functioning, and maintaining engagement through productive activities. And I'm going to just spend a little bit of time with each of these. And we just need to keep remembering that health and our perception of health is it's a self-perception. It's a subjective feeling. It's how you feel about yourself. And when we survey older people, how they feel about their health often is dependent on how functionally they are able to do the activities that they want to do. So, for example, when we teach nursing students about interviewing older adults, and often they'll say to the older adult, well, what's your health problems? And people will start listing 4 or 5 health problems. I have arthritis. I have high blood pressure. I have a little bit of diabetes. I have high cholesterol, right? And then so the student sort of gets the perception that this is somebody who sees themselves as quite ill. And then if we teach them the question, well, how would you describe your health at the present time? Often the older adults say, oh, I'm terrific. I feel great. So there's the juxtaposition of the disease and the disability and the self-perception. And it is the self-perception that is terribly important as we deal with people as they age. So there are many things that we already know from many longitudinal studies that have been shown over and over again are associated with good health. Diet, exercise, activities that promote mental acuity, and then a lot of the health screening that we do, immunizations, mammography, testing for prostate cancer, testing for colon cancer, all of the things that are preventative or pick up illness very, very early in the course of the event. And these have been shown to very much be associated with increased longevity. Now, I always look for studies that confirm pieces of my own lifestyle that I want to continue, right? And I do like, I must say, a glass of red wine. So I always look for studies that say, well, you're doing just the right thing by having that glass of red wine for supper. And this is one of them, which is that there have been some studies that show that red wine is associated with increased lifespan. So I think we have to keep all of these in perspective, right? These are things we can do to increase our chances of aging successfully. There are aspects of what we do at this time that we can't do very much about in terms of aging successfully. There was just an article yesterday in the New York Times about Alzheimer's disease and how we are going to change our gradings of Alzheimer's disease to recognize that the disease probably occurs much earlier than the more profound symptoms that we think about with dementia, such as loss of memory and so forth. Right now, there's not a huge amount that we can do to prevent dementia in old age. But there is an enormous amount of research going on, and I think people really need to stay tuned for that. And I always tell people it's interesting to think about old age if we could, quote, cure or prevent dementia. Think about if 10 years from now, we understood how to prevent dementia with old age. And dementia for people 65 and over is about 5% of the population has some dementia. But once you get into advanced old age, 85 and older, it's a much higher number, maybe a third. Some people even give higher numbers than that. So just imagine envisioning your own old age if dementia didn't exist. And it really does change our view of aging. So this work is very important and very, very important in terms of the research that's ongoing. Minimizing disease and disability. One of the areas that Jack Rowe mentioned is a way to remain healthy and stay healthy. Health screening, attention to symptoms. You know, if your left knee hurts, somebody should look at it. It's not just aging. Your right knee doesn't hurt. This is not a consequence of aging. This is a disease process. It's worthwhile trying to understand if there's something you can do about it so that you can keep your walking program, you can keep your swimming program, you can maintain your bicycling. Adhering to treatments that prevent or delay disease or disability. And we've got some wonderful data now about how important it is, for example, to control blood pressure. And if you look at the statistics on strokes in this country, on cerebrovascular accidents, they go down enormously related to a better and more aggressive treatment of high blood pressure. So maintaining and picking up early symptoms and getting something done about them. If you're seeing a provider who says this is a consequence of aging, that is no longer an acceptable answer. That's not an acceptable answer. Yes, maybe it's a consequence of aging, but what do we do about it at this point? And then maintaining engagement through productive activities, living arrangements, work, participation in meaningful activities. There are a lot of studies about this, and I will give you an example of one in just a minute. There are many communities now that have taken as their focus creating environments that allow people to live active, meaningful life. Senior communities, continuing care retirement communities, of which I know there are several in Rhode Island. Naturally occurring retirement communities, and these are housing areas or sometimes even suburban communities where people moved in with young children while they were working. And as their children have grown up, these people continue to live in these communities, aging almost with everybody in the community aging with them, naturally occurring retirement communities. And there are many of these. In New York City, we tend to have high-rise, naturally occurring retirement communities. They're called NORCs. And in these NORCs, they have put in a huge amount of social activities, volunteer programs, and health activities so that physicians' offices, nurse practitioners' offices, so that people can age in place in a meaningful way, not have to move from those activities. And then there's been some very interesting articles about cooperative housing for the elderly, which are co-housing, which are not just older people, but older people living with college students, older people living with young families. There's sort of self-planned housing, something to think about a little bit here in Kingston, where you've got the university and students, and I understand many students after the first 2 years live off campus, and you've got older people with houses that they have rooms to rent, not just renting, but thinking about how you share environments. And this is one that was written about actually in Boston, with young people sharing houses with older people. And here you can see a person probably in their 20s helping an older adult do exercises with one of the exercise balls. So it's a matter of marrying these two populations and trying to think how each would benefit the other. 13% of people 65 and over are employed, and more than 70 and 80% of older adults expect to work at least part-time in their retirement. We've seen with the downturn in the economy, actually, that a lot of older adults have stayed in the workplace. We've seen that in nursing, especially one area that I know about where a lot of nurses who would have retired before are continuing to work because they're seeing the downturn in the economy as something that requires them to continue to work. We need to think about how to reconfigure the workplace to accommodate the experience, the enthusiasm of older adults. And one of the things I keep saying is we worry about older adults, for example, in our hospitals. We're not happy with the care they get. If any of you have been hospitalized recently, I'm sure you can cite incidents where you were unhappy with the kind of care that you got in the hospital. And we have nurses who are very close to retirement who are unhappy in their jobs in the hospital and wish they were doing something else. Why can't we create programs to harness the experience, the wisdom of these nurses on behalf of the older patients, recreate new jobs so that they would be, for example, guides for an older adult as they came into the hospital, contacts for the family as they came in, would research and create a hospital environment that was more healthy and welcoming for older adults. We don't do very much of that anywhere in our environments, but it's certainly something to think about. There are factors that contribute to continued employment, gradual retirement. I actually am only working 3 days a week now. I can't tell you how wonderful it is to have 5-day weekends, 4-day weekends. It's just great, but I still feel very energized by the work that I do at NYU in the College of Nursing. Training programs, updating skills, structuring improvements such as transportation and the work environment, and obviously some of the financial constraints to continuing to work by eliminating some of the restrictions on post-pension earnings. And then participation in meaningful activities. Social isolation, we know, is very damaging. There was a study done a number of years ago in New York City which reported that about a third of people 70 and over was what we call social isolates. In other words, the only people they saw during the day was the postman who might have brought mail, the super in the building, or somebody who, for example, delivered Meals on Wheels. Socially isolated. That is very damaging to people, not the way to age. And meaningful social interactions are really very important. I want to cite an example of social supports because they benefit both the giver and the receiver of support. And the example I want to cite is a study that was done by a geriatric physician, Linda Freed, when she was at Johns Hopkins University. And she took a group of older volunteers, people 65, 70, 75, who volunteered to be teachers' aides in schools. And she assigned some of them to do that and some of them to be a control group. In other words, they were picked at random. Some of them got to do this, some of them didn't. And they were given some training, and they were put in the schools as teachers' aides, and they were followed for many years after this experience. And what they found was that the students, the kids, and these were elementary school students, the kids who were in classrooms with these teachers' aides did much better in subsequent grades. Now, that's been shown before, that if you have good teacher aides in a classroom and you have more adults in the classroom, the kids do better. What was very interesting from this study was that the older adults who were volunteers did better. Their physical health was significantly better than the volunteers who didn't get to do this. Their psychological health was much better. They reported feeling healthier and more active. So we're looking for situations that give parity, where the giver benefits and the recipient benefits. That's the ideal situation, not just a do-good job where a volunteer comes in and does work. So we have lots of things to think about as we think about how we create a humane society for everybody living in the society, including older adults, and how to keep older adults healthy and participating. But we also have a lot of older adults in our society who are frail and sick and in need of care. And most vulnerable older adults are in their very old age. Frailty in aging is much more common when people reach 80 and 85 years of age. It's more common in people who live alone and are widowed. It's more common in adults who don't have living children. It's much more common in minority elders. And by the way, here in Rhode Island, you've got a large rural population. Frailty is much more common in the rural population also. And it's much more common to be frail and vulnerable if you have both physical illness and cognitive illness. So if you have both heart disease and dementia, diabetes and dementia, you are much, much more risk and vulnerable as an older adult. There are some lifelong factors that are known to be associated with frailty. Education is protective, interestingly enough. So those of you who are students here at the University of Rhode Island, in addition to giving you your skills to get work, this is a life insurance policy, okay? Your education. This is going to help you age well. Socioeconomic status, healthful lifestyle, access to health care, and obviously a favorable genetic profile. And, we have begun to talk at the Hartford Institute of health care of older people as being the health industry's core business. This is the core business of what hospitals are in, nursing homes are in, home care agencies are in, and practicing primary care providers, nurse practitioners, and physicians are in. 50% of the nation's hospital market are people 65 and over, 75% of home care, and 90% of residents in assisted living and nursing homes. And old people make up the predominant areas of specialty practice: cancer, heart disease, urology, ophthalmology, critical care. You name almost any area of subspecialization in healthcare. And if you look at the patients that are being seen from Monday to Friday, the predominant population are people 65 and over, and especially people 75 and 80 and over. And older adults in the hospital are a real vulnerable population. They are the patients that get into trouble. Many of them have anemia. Many of them need respiratory therapy. They have heart disease even if they didn't come in for heart disease. They get urinary tract infections and pneumonia, and they have congestive heart failure. So this is a sick, vulnerable population. Now, we have spent a lot of time at the Hartford Institute thinking about this population, and sometimes it's useful to take yourself out of your population and put yourself into another population that's a specialty population. And here I'm talking about children. If you deal with institutions where children are their core business, children's hospitals, for example, or pediatric practices, if any of you go into a pediatrician's office with your sister or your friend's child, your own child, your grandchild, it looks like primary colors predominate, right? There's toys, there's pictures, there's all sorts of things that remind you that you are in an environment that caters to children. If you go to children's hospitals, it's the same thing. This is Schneider's Children's Hospital in Long Island, and it announces itself, right, as a children's hospital, right as you come into the parking lot. This is the whimsical structure. You go on the website of children's hospitals, and you will see that they're all about children. And this website says, this is the Duke Hospital, Children's Hospital, and it says, our mission is to provide excellent care to children. It is a children's hospital. If you go into almost any hospital where the predominant population is 65 and over, it makes no announcement at all that is its predominant population. It doesn't make any special plans for where you can park so that you can get there if you're 85 and over and visiting somebody. It doesn't present materials in large print. It doesn't have promotional materials that says, go to our website. There's a hospital website will tell you everything you need to know if you're a patient 65 and over. It does virtually nothing. It has no equipment made for that population. And I would tell you, there is a science to all of this. All of this exists. It just isn't there. We have a program at the Hartford Institute called Niche, which helps hospitals nationally think through how to create an environment that's receptive and welcoming to older patients and their family. And it stands for Nurses Improving Care to Hospitalized Elders. It focuses on programs and protocols that would help nurses take care of older adults. It's got a number of sites here. It tells you a little bit about each hospital. And this is the website of a hospital in Michigan that is a niche hospital. And if you look at the buttons across the top of this is their home landing page. It says children's health, women's health, men's health, senior health. So if you wanted to find out if there was a doctor or a nursing group in the hospital that specialized in care of older adults, if there were special programs, you would find it on the landing page. Now, interestingly enough, here in Rhode Island, Roger Williams Hospital is a niche hospital. So I did go to their website, and here are some shots from their website. This is their landing page, so this is their homepage, and it says behavioral medicine, cancer, diagnostic imaging, elder care, with the yellow arrow points. There are 300 niche hospitals in the country. Maybe there are 350 now. There are 15,000 hospitals nationally, okay? 300 hospitals where you could go to their websites and find something specific around older care, aging care. 15,000 hospitals, so 14,700 where you probably couldn't do that. And this is another website shot from Roger Williams Hospital, and it talks about home care, geriatric psychiatry, inpatient care, and extended care. And this is the last one from the website because it talks about the hospital as being a niche hospital. Now, does that mean that care for older adults in Roger Williams Hospital is perfect? No, it doesn't mean that. It means that the hospital has committed to being on a journey to improving care. It means that you should find somebody in that hospital who should be able to help you around issues, for example, of taking an older family member home. It means that there's a commitment. It doesn't tell you that they've met every aspect of that commitment. So that is the issue around the core business of healthcare and where we are. And part of the problem is that we don't have enough healthcare professionals prepared in geriatrics. So if you can see here, there's very few social workers, pharmacists, physical therapists certified in geriatrics. There are very few nurses certified in geriatrics. Less than 1% of the practicing nurse force are certified in geriatrics, and there are very few geriatricians nationally who are physicians certified in geriatrics. And this has relevance to care of older adults because older adults experience illness and present differently. They don't necessarily come in and say, I have chest pain and it's radiating down my left arm and I think I have a heart attack. That's not how they necessarily present. They'll present saying, and somebody will come with them and say, my mother's really confused. We don't know why she's so confused. She's fallen, and we didn't expect her to fall. She's got some incontinence, and we don't know where that's coming from. They present differently, frail older adults, and you need people who are tuned to pick up some of that frailty and can follow it through to understand what's happening. So the fact that we don't have enough professionals prepared in geriatrics is an ongoing problem. But here are some of the things you can do as you get out into your community in terms of at least asking for this kind of health care. So you can go and inquire at your hospital and see what programs they have for older adults. Is there information for older adults and families on the hospital website? And if not, why not? Do they have nurses or doctors or pharmacists who are credentialed in geriatrics? And what would it take to get a few of these? Why doesn't the hospital have some commitment to that? Do they have special care units for older adults, such as an acute care unit or an ACE unit? Do they have special programs, such as niche or other programs? There are many hospitalists now in the nation who are physicians who work primarily in the hospitals. I think you will know of them if you've been into the hospital. The Hospitalist Physicians Association has a program called BOOST, B-O-O-S-T, which is specifically focused on helping hospitalists from the day an older person comes into the hospital plan their care so that it can be smoother and they can have a smooth discharge back to the community. So there are programs out there. The issue is to get them into more places and accepted into more places. And do they collaborate and share education about care of old adults with home care agencies and nursing homes as patients transition between all of these places? You can ask of the nursing homes in your community. Do they have nursing and medical staff prepared in geriatrics? Believe it or not, we have nursing homes around the country, and many of them, most of them, have no nurse certified in geriatrics and no geriatrician overseeing medical care. So, and no nurse practitioners with preparation in geriatrics. So it is a real problem in how we take care of patients in nursing homes. Do nursing and other students have clinical rotations at the home? So is the home open to new ideas? Do they have programs to prevent unnecessary transfer of patients and residents being ping-ponged from the nursing home to the hospital and back? Do they have special programs for residents with dementia? Now, I just want to spend a few minutes on women's health because women's health is a big issue in aging. As I said, there are more women 65 and over than there are men, and we have some rather troubling data that women tend not to get the same level of health scrutiny or health care than men of the same age and with the same disease. They're less likely to receive routine preventive care. They have very little opportunity for one-stop health shopping. If you have a primary care provider as a woman, it is unlikely that they will provide your gynecological care. You have to go to a second nurse practitioner or physician or midwife to get that level of care. And every time you add another layer of complexity, less gets done in terms of people's willingness to do that or their ability to pay for those services. There are limited opportunities to pursue healthy lifestyle in minority and rural communities, access to gyms and health clubs, access to affordable healthy foods, access to public transportation. I spoke to a woman discharged recently from Mount Sinai Hospital in New York City who lived in Harlem. She had come in, she'd been very sick, and as it turned out, she had been obese and she had lost quite a bit of weight. And she was very anxious to maintain that weight loss. And so we began to talk to her, well, you should go to a gym. And she looked at us and she said, there are no gyms in my community, certainly no gyms I can afford. Well, you should walk. Well, she said, you have to come see my community. It's not so healthy to walk in my community. Well, what about healthy foods? Well, she said, there are no supermarkets in my community. I'm dependent on small stores. They don't sell healthy foods. They don't sell vegetables. They don't sell fruits. Well, you should make sure that you at least pick up your prescriptions from the pharmacy. Some of these prescriptions I can't get in my pharmacy. So, I mean, once we start putting barriers like that in front of people, those are pretty profound, right? You can't really fault somebody for saying, I can't get this done. There's less likely to be screened for life-threatening illnesses. If a woman comes in with chest pain, there have been some studies to show that she is an older woman. She's less likely to get a full workup than an older man with the same symptoms. They're undertreated or mistreated, and they're very underrepresented in terms of mental health services and clinical trials. So as an older woman, you just need to be sure that you're paying attention, and as a healthcare provider who's advising and taking care of older adults, you need to be particularly heads up in terms of older women. And obviously, this is a picture of an older woman, and you see who she's exercising with, right? She's exercising with kids, okay? So in each of these communities, there are schools, right? Why can't the schools create an environment where there's gyms in almost all of these schools? Why can't we have to think a little bit about how to create some of this? And then I want to close with some comments about family caregiving. Family caregiving is a very, very common event in American society. We tend to think of societies such as Asian societies and African societies as being family-friendly, and Americans as sort of abandoning our older people. The data actually do not support that. The data do not support that. The data support that there's an enormous amount of family caregiving going on in the United States. In fact, there is more time lost from work for elder care than there is for child care. More in the workplace, if you look at time away from work and you compare time away from work of workers for child care and for elder care, there's more time away from work for elder care than there is for child care. So there's an enormous amount of family caregiving going on. 80% of all caregiving to older women is provided by family, and here's the data on time away from work. And I just want to mention some problems with family caregiving from the perspective of the older adult who's providing the family caregiver, because the most common caregiver is the spouse or a sibling or somebody of the same generation, and then children. But remember, if you're caring for a 95-year-old mother, you yourself are likely to be in their 70s, right? If you're the daughter taking care of an older mother and the mother is in their 90s, you yourself are elderly. So there's a lot of data to suggest that caregivers themselves neglect their own health. And so I just want to end with just a couple of slides on this about paying attention to your own health needs as a caregiver. You're at risk for physical and functional and mental illness. Paying attention to your own work and social needs. Staying in the workforce promotes your current involvement, but it also has real profound implications for your retirement income if you're a caregiver. Contacts with family and friends provide you with the social supports, and involvement in activities that provide pleasure improve your mental health. So if you yourself are a caregiver and find yourself isolating yourself, you need to really think through how you're going to structure your caregiving needs and balance them with your own needs for your own well-being. And if you know a caregiver, or if you're a healthcare professional and you're working with caregivers, you need to be sure to ask the caregiver how they are attending to their own sense of well-being and care. And as I said, caregiving is a women's issue. I think we've said enough about this. So there are some tips that you can use as a caregiver when you're encountering healthcare providers in terms of how to give the healthcare provider a picture of who this older adult is. You know, when you go into the hospital and you're 95 years of age, it's likely that the nurse providing care to you is, I don't know, if they're a new graduate, maybe they're 28, 27. If they're a little older, they're 32, 33. They see you as a very old, debilitated. You're at your worst, right? If you were at your best, you certainly wouldn't be in the hospital. And you're at your worst, and you're sick, and you're trying to create a relationship with the healthcare provider, the intern, the resident, the nurse, the pharmacist. You're trying. So I always ask family members to humanize this person for the staff. Bring in a picture of this relative who's in the hospital when they were about the same age as the staff. So the staff can actually see, hey, maybe this person used to look the way my friends look when I leave work. I always say if this older person ever rode a motorcycle across country, bring that picture in. Something to make this person alive, real. Bring in anything they've written. Bring in recipes that they like. Tell people the music they like. Humanize this person for the staff so that the staff, and if you go into good nursing homes now, at the entrance to the rooms of residents, because of course many of the residents are cognitively impaired and cannot tell their own story, they have put boards in the nursing homes with pictures and stories of who this person is, not who they were, who they are. They're just a continuation of themselves, to try and get staff to understand who this person is that they're dealing with. Remember, if you're a caregiver, to report small changes in your relative, because the small changes are often harbingers of something more profound, and tell people the response of the person in terms of how they respond to illness. And then, if you're visiting somebody in a nursing home, try to think through how you're going to create those visits in a way that are meaningful, and ask the staff to help you do that so that you and the person that you're visiting, especially if they're cognitively impaired, can maintain the relationship that you've had over many, many years. So I'm going to close with this slide, and then we will have, I think, about 15, 20 minutes for questions and comments, which I hope we will have many of, and we have mics that we can circulate in the room for your comments. There's a statement that says aging is not for sissies, right? We've seen, I think many of us have seen that station. What we're trying to do now is we have this enormous expansion in longevity, enormous expansion, people likely to live to 100 years of age. And we want to balance that against quality of life. What is the quality of life that we can create so that being 95 is a joy, not a terror? And what I've tried to hopefully point out today is that there are some things that you can do early on to help get you to a quality old age. And there are certain things that maybe you can't prevent, but that you can at least demand of the healthcare system to help you have as a productive and joyous old age as is possible. Thank you very much. So we need hands up for questions, comments. I know even from the group that I had lunch with that there are questions and comments. So
thank you. It was a wonderful talk right here.
Thank you.
I'm from the Community College of Rhode Island, the Occupational Therapy Assistant Program. So can you tell us maybe how occupational therapists can help you in your
Occupational
trying
therapist.
to do this? Yeah.
Oh, occupational therapists. And I didn't dwell on all the therapies, but occupational, well, you can probably give some examples, probably better than I can. Come back with the mic. Let's ask this gentleman to cite it. I'm not going to cite occupational therapy examples. You're going to do that.
Okay. Well, no, a lot of the things you talk about, just simple things we discuss in our classes, just how people age, so we really understand the aging process. Basically, as you get older, everything just starts to break down slowly, slowly but surely. Your vision starts to go, all these little things. So we as occupational therapy assistants work with OTs and trying to say, okay, how can I get this person to the highest level of function, their highest quality of life? But you have to understand, as a student, we have to understand that, oh yeah, this person, it's not that there is a cognitive delay or they're losing cognition. Maybe they can't see something as well, so like the large print. It makes sense. Even I'm 51, so I'm starting to hold things further over here. I got to put my glasses on to see things, where I never had to before. So I'm feeling the effects of aging. But little things like making a chair height a little easier, or a chair with armrests you can get out of, makes it easier functionally to get around. But as OT, we really, I just went to the national AOTA, the American Occupational Therapies. There were 6,000 OTs there in Philadelphia this last weekend. And they're all looking at this.
Absolutely.
And it is a huge impact on where people are going. To age 100 is the fastest growing population in the country, I think they're saying roughly, and probably what you said too, So yeah, I mean, we as OTs, we are looking at that really big.
Great.
And it's really encouraging to hear you say those things. Everything I felt like it was in my OT class. We really need to look at that constantly and
Great.
challenge ourselves. If you don't dream big enough, or somebody said at the conference, if your dream doesn't scare you, you're not dreaming big enough. You got to dream big. You may not reach them all. Maybe have 5 big things I want to do. Maybe I'll only do 2. But guess what? If you didn't dream big, you're not going to get there.
Great. And by the way, most of us who work in geriatrics really embrace the notion of a team approach to care of older patients, because when I describe an 85-year-old person with all of the physical declines, the diseases, the cognitive declines, the functional declines, this is the person who really benefits from bringing nurses to the table, physicians to the table, pharmacists, PTs, OTs, and very much a benefit to care. Over here. Well, let's get you the mic, and say who you are.
Hi, I'm Donna. I'm currently working home instead. I've been a nurse for almost 40 years now. And the quality of hospital care has made me very sick as far as the kind of hands-on nursing that people are getting in the hospital. And you were talking about the older population. Is there an advocacy group, like a nurse advocate for the patients, that we can start with the older nurses who've had all these years of experience? Have you heard of any?
Well, that's a wonderful question. The question is there an advocacy group of nurses who could, and actually, there's an advocacy group for residents in nursing homes, which is the National Coalition of Nursing Home Reform. I don't know, Pat, I don't know if you do either, of an advocacy group for nursing in terms of, I don't know if you belong to any of the associations that represent nurses working in long-term care and in aging. But we have pulled together, there are 8 associations representing somewhere around 30,000 nurses, where the nurses are likely, highly likely, to be working in situations which are almost 100% older adults. So nursing homes, geriatric nurse practitioners, and we've created a coalition of geriatric nursing organization, CGNO, and it's on our website if you just Google it. But we have never thought about that. So we take advocacy positions on the part of those 8 associations, assisted living nurses and so forth. But your notion of an advocacy group where nurses working in the field could say, actually, I'm not aware of any group, and it's something really interesting to think about. So that's a very interesting idea. Other questions or comments?
I will celebrate my 90th birthday December 6th. And the only complaint I have is short-term memory loss. My body is in excellent health, and I can say that my biggest help is my faith in Jesus Christ. When I turn to Him, I get an answer, and anything I'm complaining about improves. So that's all I have to say.
Well, and that's really wonderful. Thank you. And obviously, spirituality is a major supports many people as they move into old age. So if you are somebody for whom spirituality is really important, and you maintain your contacts around that spirituality, and then that again is your social network. It brings you into an embracing group. And anything that you can do like that is very helpful as you age. And that's not just me saying. I mean, there's some pretty good studies that show not the spirituality only, but the being embraced within a community of spirituality can be very helpful. Okay, right down here. Oh, back here first.
My name is Doris, and maybe you've covered this because I came in a few minutes later. Being a person that enjoys people of all ages, so far, my husband and I have been able to live in a neighborhood composed of various ages. And we're fortunate enough to everyone is extremely friendly and very caring for one another. Are there any studies regarding people that like a mixed community versus going into a setting in a nursing home or assisted living where the majority of the people are elderly? And are there any statistics regarding one versus the other?
Okay. It's a really good question because when I've lived long enough to have watched the age-segregated communities grow up, the ones in Arizona and in the West, and there was a lot of feeling that these age-segregated communities were going to contribute to increased longevity. But I think there are several probably things to speak of here. The first is that the community that you live in is not the important thing. The sense that you are at home in the community you're in is the important thing. So certain people really don't want to live in an age-segregated community. They want to bump into children on bikes every day. I always say that the very best place to age, but this is, of course, my bias, is the middle of Manhattan. And I do believe that, by the way. I think the middle of Manhattan is the very best place to age. I can get every service. The issue is that if you live in your home that you've lived in forever, that's what I'm doing right now, and you stay there, there's a risk eventually that you will be alone in that community in terms of your peer group, your cohort group. And when that happens, if you then find yourself isolated, that is not a good thing. That's not healthy. But other than that, there aren't really studies that I know of, unless somebody else from the audience wants to. Pat, anybody want to add anything to this? Okay, we had one question down here, and then I think that's going to be our last. Is that all right, Phil? Last question.
Hi, my name is Donna, and
I can't hear you very well.
is it on?
Yeah.
My name is Donna, and I am a nurse. I work in the community with the elders. I work for a CAP agency, and we have the contract with the Department of Elderly Affairs. So I see a lot of the abuse cases, the self-neglects. But what I'm seeing is an increase in the the young elderly population, the people who are just turning 65, who have many more psychiatric issues, a lot of vets. Yes, Dave. And that's something that I have a very strong psych background, so that's come very helpful to me. But I'm not sure that, generally people think of the elderly as being Vietnam vets. I mean, we had the World War II vets and the Korean vets, but they came back and they were heroes. And the people who come back from Vietnam haven't been treated quite as well. And I think that's led to a lot more issues in the community. We're seeing a lot more of that. So it's just something to keep in mind.
So the notion is the veterans. Is that I didn't hear you very well. Can you repeat?
Yeah, the Vietnam era veterans, they're all turning 65 or, have just turned 65. And the acuity of that elderly population is kind of rearing its head right now. And I've just seen so.
And by the way, I touched on it, but the mental health services for older adults are very, very lacking all over the country, not just for vets. The mental health system is not very well set up for older adults with mental health problems. There are very few providers that have had any preparation in mental health issues of the elderly. In medicine, there are geropsychiatrists. They have an association. The geropsychiatrists that I know are wonderful, but they're very few and far between. And actually, in nursing, there is a geropsych program here at the University of Rhode Island College of Nursing, correct, Pat? But there are very few geropsychiatric nursing programs in the country. They tend to have few students, so They're always at risk when, people are looking to close programs. But they're really critical because there are very, very few people with that training. So it's a real problem. All right, thank you very much, and thank you.
Thank you, Dr. Mezey. I think you've given us a lot of thinking and ideas that we can use in our own lives as well as in the lives of members of our family to promote successful aging. So thank you for being our 6th annual Malford Thewlis Lecturer, and I would like to invite everyone at this time to join us across the street at the URI Alumni Center for a reception to honor Dr. Mezey, and you can, I'm sure, ask more questions at that time. So thank you all for coming.